All right, welcome back to another PCBH Corner. I'm so excited about our guest, Rodger Kessler, which I'm sure a lot of people that watch the PCBH Corners have seen his name pop up regularly, whether it be through publications and academic journals, or whether it be presentations at conferences or on listservs or whatever it means. I think Rodger's a name that a lot of people know. And the thing that I'm really excited about within this is that I've gotten to know Rodger a little bit better over the past couple years. And it's one of the things, and we were talking off camera earlier about, I really don't know anything about Rodger's like beginnings. I don't know anything about Rodger's kind of like how he got into integrated care and being, on the forefront of the research and developing, one of the more common assessment tools of how integrated the place is. I really don't know the story. So that's the first thing, Rodger, I wanted to kind of ask you, and maybe within that, give yourself a little introduction, what you're working on currently. But what got you into integrated care? What started this journey?
A series of accidents is really what happened. So I, got my PhD, had a private practice, was doing very well, sufficiently well to need bigger space. Family doc had a building that had half the building empty and rented it to me with and it the private practice flourished and became one of the largest in the state of Vermont. And as I was doing my practice, more and more I was noticing I had a traditional clinical psychology training. There was nothing about my training that had anything to do with medicine. So I started to notice that a lot of, and it was a very active referral back and forth from the physician. And I started to notice that a lot of the things that I'm seeing people, the medical issues and the behavioral issues had a lot of overlap. And I just kind of found that interesting. And, we started talking about that with the physician and started focusing on I had a big group, so anybody could be seen, but I was seeing patients primarily with medical issues. And as I was doing that, I was sitting around one day with another psychologist buddy, and he was saying he was going down the road to the local community hospital. This is in northern Vermont. And he was going to this really small rural primary care hospital. And he was going to say, if you need any assessments done, why don't you do them? And I'll do them. And he said, well, why don't you come along to this meeting? And I did. And another meeting got rescheduled with the medical director of the hospital. And he said, I heard you were working with this primary care doctor, and that's very interesting. And you know what? That's an area we've done nothing in. So, I think there's a place for you here. And I said, well, I don't know. I mean, I'll do a group, or I'll do, psychotherapy as needed. He said, but I'm leaving the hospital, so I'm gonna, oh no, actually I started with the social worker at the hospital. And he bumped me up to the medical director, and the medical director says, I'm leaving, but why don't you go talk to the president of the hospital? So I go sit down with this person, and I said, blah, blah, blah. I still have no clue about anything. She said, well, this is great. Get me a proposal. And I said, a proposal? A proposal for what? They said, a department in the hospital. So the bottom line was I started a Department of Behavioral Medicine in this rural hospital. It was the first in the state. Um, and, we just wound up becoming the largest provider of behavioral care in this rural county.
Hmm.
But with not really rhyme or reason. It was, a psychology practice or a behavioral practice. They wouldn't pay psychologists. So these are all master's level people, I think, getting paid a pittance. And, it was just a referral model. It was not integrated in any kind of way. It was just a co-located place in this building abutting the hospital. And I continued. This will take me about 2 more minutes.
Oh, you're good, man. I love this. These are the stories we want to hear.
I continued my private practice and had been treating a woman. The other thing I didn't mention is I got increasingly involved in mind-body interventions, trying to figure that out, and got very involved in applying hypnosis in clinical populations and clinical behavioral / medical populations. So I had this patient that was working with and doing good stuff, doing good work with hypnosis. And she walks in one day and says, well, I have to have, and she was recovering alcoholic. And she said, I have to have an abdominal hysterectomy. And, I saw the anesthesiologist and I told him, but I won't take any anesthesia because I won't put any of those kind of chemicals in my body. So I said, I have this psychologist who's going to do hypnoanesthesia. And she comes in and tells me this. And my response, of course, is no. I've never done anything like this. I know nothing about it. And besides, I have no privileges in this hospital and blah, blah, blah. And she said, well, we'll work it out. And the short story is the anesthesiologist, who has, become one of my best friends in the world, thought it was a great idea. And the thing was scheduled during a time when the chair of anesthesiology was out of the country. So, with no privileges, I gown up, go into the thing and do this work. And the surgeon, who also wound up becoming a great friend, is a very mind-body oriented surgeon. So he thought it was great. And the bottom line was, it was an incredibly successful procedure. We had talked her into taking a small amount of regional, which wore off, a third of the way. And she started moving her toes and moving her feet. And they were all freaking, but the patient wasn't. So I get done with this thing and, I'm flipped out completely. And the anesthesiologist and the surgeon come up and say, whoa, this is unbelievable. We need you here. So come become a member of the Department of Anesthesiology.
Whoa.
So I start hanging in the Department of Anesthesiology, and the focus of that work is pre-surgical preparation. So I spent a number of years with my primary focus being seeing patients prior to surgery, who either had high anxiety procedurally, or they weren't coping well, or they had medical histories that were complicated, or family histories that were complicated. And that was working great. And I enjoyed it. It was very brief, focused intervention, saw folks once or twice. And then at lunch one day, one of my mentors back then said, if you want to get involved in the medical staff, eat lunch every day in the cafeteria. And so I did, and actually it was a decent cafeteria, but, I sat and I got to know everybody. And one day, one of the docs from the largest family practice on the campus, comes up to me and says, you see a lot of our patients prior to surgery. And we have a lot of patients who really need behavioral interventions. So would you think about, coming over and practicing as part of our practice? And I said, sure, I would love to do that. The bottom line is that was Berlin Family Health, which I wound up staying at for 25 years plus, and got really involved. One of the interesting things is, as you know, if folks know me professionally, I have a great deal of respect for my psychiatric colleagues, but I have no respect for psychiatry. Um, and I certainly wasn't going to be supervised by any psychiatrist. And so in all across my career in the three medical centers that I've been part of, each one, the medical staff passed a bylaws change to allow a psychologist to be an independent practitioner on medical staff. So that was pretty cool. I was the first psychologist to become chair of a major medical staff committee. I was in charge of the utilization review committee for a couple of years. So I keep stumbling into this stuff. And then, when I'm sitting in family practice, I'm saying, yes, I get it. Everybody's telling me, whoa, Rodger, man, you're so cool. You're doing this stuff in family practice. Nobody else is doing the blah, 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 blah. And so everybody wanted to do this. So I started developing other practices doing similar things with lots of constraints. So, we developed practices in neurology, in OBGYN, in allergy, in internal medicine, blah, 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 blah. And so that was all pretty interesting. So I became a bureaucrat, kind of developing and managing those things. The insurance companies were fairly flipped out by it. They loved it, but didn't know what to do with it. And because, as you know me, I'm a fairly blunt guy.
I appreciate it. I appreciate it.
And I was saying to him, hello, I'm happy to spend your money, but it's unethical and it's probably illegal for me to be billing psychotherapy codes when I'm not doing psychotherapy. And they were totally stumped about that. And frankly, I did not make a great deal of headway other than everybody got it, but they didn't know what to do with it. So I started saying, I gotta figure out whether this really is doing anything. So it doesn't matter if I'm here in family medicine or if I'm in my private practice. I mean, are the patients the same? Are patients different? Do they come to see me more frequently, less frequently? Those kinds of things. So I started asking that question, and we developed a behavioral prescription pad. So, and anytime somebody wanted to send me somebody on referral, they would spend 30 seconds just giving me some basic information about the patient, about why they wanted me to be engaged. And then they would send that back over to me, and I accumulated, a number of hundred over a 2-year period of time, number of hundreds of those, and looked and found out that on average, 90+% of the folks referred to me in family practice, in fact, showed up to implement care. So I said, well, that's pretty high. How does that compare to what the literature says? And went to the literature and found out that there was actually very little in the literature about that. But in the general case, 20 to 30%, care initiation, if referred from primary care to the private world. And that became the nature of my first family medicine publication. And so the way I operate is I consider myself to be not very bright, but pretty stubborn. And when I get into situations over my head, I just call up my friends, put on this, sad look on my face, and essentially say, I need help. So I contacted a bunch of folks, Dan Mullen, Ben Miller, some other folks, and said, this is what we did, and this is our finding. We should do this nationally. So in fact, we came up with I think it was 5 setting card study doing the same thing, and demonstrated that on average, about 75% of the folks who get referred for behavioral care in primary care show up for care.
Show up.
So that was interesting. And so I said, I kind of like this idea of getting this data. And I started thinking about data more and more. And then one of the big deals from the university shows up for a lunchtime C&E, and it touches on issues of depression in primary care patients. And I said, blah, 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 this is what I do. I mean, he said, oh, you should talk to this dude up in the university who's interested in this stuff. So I talked to him, this dude up in the university, and he sits down and says, you know what? I might be able to recruit you as a fellow in the Center for Translational Sciences in the medical school. And, should we do that? So I became a fellow in translational science. And then, all along the way, I developed these contacts in the Department of Mental Health and blah, 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 blah. So they wanted to write a grant. It was one of the first SBIRT grants, actually. And I don't remember exactly why I got involved in it, but I wound up writing the grant. And so I was saying, well, the medical school is going to do this, the medical school is going to do that, we're going to do all these things. And it's like I had no standing, I had no appointment, I had no nothing. And I was making these commitments for the medical school. That's what happened. And along the way, I wrote an email to the dean of the medical school and I said, Mr. Dean, sir, I'm making all these commitments for you and I have no standing. And is this okay? And what should I do? And he said, well, you know what I'm going to do? I'm going to make you an assistant professor of family medicine. Without even talking to the chair of family medicine, which wound up being one of the major bones of contention over my stay at the University of Vermont. And I became an assistant professor of family medicine, did more integrated practices. People have heard of the Blueprint for Health in Vermont. Vermont now is identified as the state that has the highest proportion of behavioral clinicians in primary care practices in the country.
That's cool. That is really
and I did the first one. I was doing all that kind of cool stuff. And then Ron O'Donnell, at some point, I don't know if he read I think he read a paper. And he called me up and he said, you know what, we do a conference every year. On integrated care, and why don't you come out and do a presentation? So I said, yeah, that'd be fun, So I went out to Phoenix to the Doctor of Behavioral Health program and did a presentation. I don't remember the presentation much. And, spent time with those guys. And at some point in time, I got an email back essentially saying, you got to become part of our faculty. Every time, I am not a city boy. This background on my video is from the island that I'm moving to in a month. And so, I lived in the mountains, couldn't see another house, just mountains and forest. And that's how I like it. So every time they would send me, we want you to come be a faculty, I would send them back this thing. a picture or something like that saying, you know, I can't do this. I mean, this is where I live. This is how I live. So finally they said, okay, look, you tell us, what do you need? If you were to become part of the faculty, you know, on a regular basis, what would you need? So, you know, I made some outrageous, at the time, financial demand. I said, you know, I only come to campus once a month, and I am not coming to Phoenix between May and October, period. You know, I do not do that kind of weather, which, you know, I wasn't able to completely get to. So I became faculty at Arizona State and hung out there for a while. And in the interim, back in Vermont, we had been playing around the idea of trying to get a PCORI grant, looking at integrated care. And the interesting thing is, back in the time, so Carrie Stevens, who you should actually ask to do one of these, because she's—
That's a great idea, right?
Yeah, she's the brightest and the best.
Yeah.
She's one of my— and another person would be Connie Van Egan, who is one of my Vermont colleagues.
Oh, I don't know Connie.
Whose vision is, how do you make this work in the world of organizations? And she's really good. But anyway, Carrie and I had this idea that we need to demonstrate the effectiveness of integration. And I went around and I asked all the major figures that I knew in integration, will you please be PI? Because frankly, they weren't going to give no money to me or Connie or Carrie, rather, to do this. So the bottom line is, a colleague of ours at the University of Vermont, an internist, who he was the one who started me down the path of the fellowship in translational science, became PI, and we did the IBH PC project. And so that's one of the major Vermont pieces. The other thing that we were doing in Vermont that I continue to work with is the question around, does the level of processes that you have within your organization and your practice influence outcomes? That is to say, is the level of integration predictive of anything? And that wound up being— and so we developed this thing that started at the Vermont Integration Profile. It became the Practice Integration Profile. Now PIP2, Dan Mullen at UMass is kind of the gatekeeper of the PIP2. And we had multiple thousand responses to the PIP, and we knew some stuff. And part of the amazing outcomes of IBHPC is, and you know, our paper is in process at the moment, our primary paper, your level of integration in the practice is absolutely associated with patient outcomes. And that's important enough. But what we've most recently discovered is a particular score level. The PIP is a 0 to 100 measure. And we have discovered that in this fairly well-designed and controlled study of 40 practices around the country, we've discovered that a score of 65 and above needs to happen to be associated with patient outcomes.
Wow. Below
65, there's a very low probability of you achieving that relationship with patient outcomes.
Now, and how many, what was, do you have like the breakdown of how many practices within that data set was above 65 versus below 65?
I would like to have that on the top of my head, and I unfortunately don't.
Okay.
But I will pass that on to you. I actually have a graph that displays that data.
Because this goes into
more lower than higher.
That's what I was going to ask you, because this goes into the conversation we were having a little bit before the camera, right? About like, hey, if we looked at the the average integrated care effort that's happening across, primary care offices or other offices and stuff, do we actually think that's producing benefit or improvement in patients? And what would your response be? So if based on the data that you've seen, that like the average, the mean, the what would you say the probability is that produces better outcome?
So if that holds, that number holds, and Carrie and myself and Connie Van Egan and Dan Mullen, and there will be other folks, are starting down the road of a next major national project to evaluate those questions.
Okay.
Because they were secondary findings and we need to make them primary findings.
Okay.
So anybody interested in playing on this project that's listening to this, please get a hold of you or get a hold of me. I'm going to hassle you to be involved in that project also. But, if that finding holds, there is a really profound question. And in the dissemination and implementation world, which is my focus on the universe, there is this question about de-implementation. That is, if in fact you can't demonstrate the effectiveness of an intervention, should it be maintained? Or should you discontinue it? Should you de-implement it? And we all know the challenges of doing integrated care. They pale compared to going in and saying, stop doing integrated care. Because as your own data shows, from your place, the practices love it.
No doubt.
And part of the reason the practices love it is you and your partner, because you've done such a good job. But part of the reason is it's a big deal. And that it's a big deal is a different question, is it effective? And the field has ignored that. And one of the concepts, so let me just finish this tale. IBHPC, part of the reason they told us that they funded us was we had the dream team of investigators. And what I mean by that is Kurt Stange, the editor of Annals of Family Medicine, Rodger Kessler, Frank Degree, just the major figures in primary care. So we had these annual meetings and bringing all the investigators to Vermont. And during one of those, I had dinner with Frank Degree, and Frank Degree has been one of my primary mentors for much of this. I don't have any recollection as to how that started exactly. But, on and off, he had talked to me about the idea of, or we had discussed having an adjunct appointment at University of Colorado. And, University of Colorado Family Medicine has been identified for a long time as the pantheon of family medicine practices for integrated care. And so we're at dinner and we're in a conversation, and finally he says, let's get rid of this adjunct stuff. Just come and be a member of the department. So I have had the remarkable and unexplainable, wonderful opportunity to, under Frank's mentorship, he's now retired as chair, become a member of the faculty at University of Colorado Family Medicine. And, the circle is almost complete in terms of, how I stumbled through all of this stuff and got involved. And here I am now, involved in a number of projects. A few of them have directly to do with behavioral health integration, although that's about to change. My work is, I do work with diabetes, I do work with COPD, I do work with asthma, and a chunk of my time is spent trying to figure out the issue of systematizing telehealth and telehealth care interventions. And I'm particularly interested in rural and frontier practices who have gotten the short shrift of behavioral health integration. And one of the people who has really helped my career along has been Sandy Blunt. And I consider him a wonderful friend as well as a mentor. But part of what Sandy did and some work he did in New Hampshire was develop a 3-level training program for medical assistants and how medical assistants can engage and provide behavioral care. And I've become really focused on that. We did a project in Phoenix when I was at Arizona State in a health system that had no behavioral health whatsoever, yet came to us and said we had, excuse me, I can't believe I'm ranting and raving with only having had a half a cup of coffee.
I love it, man. This is the shit like we could talk for days about.
Yeah. So they came to us and said, you know, a lot of patients with type 2 diabetes have behavioral comorbidities. And we need to do something about that. And we said, sure, we can help. You know, who do we got to work with? Who's your behavioral staff? And he said, well, we don't have any. I said, well, you know, we're good, but we're not magic. So what are we going to be able to do? And they said, well, we have medical assistants. So colleagues at Arizona State and I got funded to develop a training program. I'm trying to recall the sets of people who were involved in this, and I'm blocking on one, but Mindy McEntee, who's just an emerging star in clinical health psychology and behavioral medicine, was one. And we came up with this brief, limited training program of medical assistants, and then had them out getting referrals to co-manage the issues related, the behavioral issues related to diabetes. And over a 2-month period of time, in a relatively small sample, and we're going to be submitting an R01 to evaluate this further, we are able to reduce A1Cs in 12 weeks of almost a point.
Whoa.
Which is a remarkable finding. You know, for those of you who are not aware, changing a point in 12 weeks is a big time finding. Now, there's a gazillion of limitations, you know, to that finding, and we need to do another trial to evaluate whether it holds. But, you know, part of that work has really gotten me focused on multimorbidity. And this is really my major, I think, divergence with the field. You know, I went to, we did a panel at CFHA this last year, and it's the first time I've been to CFHA in many years, because I don't find it helpful. I find it focusing on the same old stuff. And if you laid the agenda for CFHA in 2022 on top of the agenda for CFHA in 2015, you wouldn't find very much.
Interesting.
So for me, you know, if integrated care is going to have real systematic effect, the administrative folks and the financial folks need to support it. And one of my mentees, a woman by the name of Jen Y in Idaho, has really pushed this issue and is really focusing on hold on for a sec.
No worries.
What time is? No, we're good. Really focus on getting contracts focused on what are the outcomes that behavioral health needs to demonstrate in order to for the insurers to think about alternative payment systems for behavioral health. And that whole issue of what are these outcomes and what are these metrics is a key issue that has been pretty much systematically ignored by the field. There have been 7 or 8 kind of theoretical, post CJ Peak's lexicon. There's 7 or 8 frameworks for behavioral health integration. And none of them have developed metrics. And you can't evaluate with theory. I mean, the reason that we developed the PIP was as a response to CJ. And nobody can translate CJ, so that's a given. But we did our best to translate CJ's lexicon into a measurable phenomena to be able to talk about metrics. None of the frameworks do that. And one of the godfathers of dissemination and implementation research, Russ Glasgow, who's a colleague at the University of Colorado, I passed on an observation from somebody else that says frameworks are like toothbrushes. Everybody has one, but nobody wants to use the other person's. So there are all these frameworks of integrated care. And the only data that's come out of that has been the chronic care data out of UW focused on depression and anxiety. And the rest of the field has ignored that. And when you look at the financial data about the total spend on things involving behavioral health, in fact, the cost of care controlling for severe and persistent mental illness or substance abuse, the spend for mental health and substance abuse issues, in the middle range is not much money at all, actually, in the total spend. What is the most money? It is patients with 2 or more chronic medical diseases with a behavioral comorbidity. And that is anywhere from 50 to 200 to 300% higher spend. And how often is that treated? Not at all. Part of what the research group in your shop are in the process of hassling you about is we want to look at the referrals that docs are sending to your behavioral health folks. And I'm doing this in Colorado also. And see what proportion of those patients have 2 or more chronic medical conditions. And if the behavioral data is coded, what is the proportion of the referrals that are specifically to assist management of the chronic medical condition? And our guess is it's going to be damn close to 0.
You know what's interesting, Roger? And this is what I'm going to respond to you all with it. So we do have some data about tracking. Now, the problem is, as you're saying, like the patient to patient, like, can we follow this patient through this process and stuff? So this is more just a gestalt. What we actually found was that when we looked at the initial referral problem, about 54%, I was actually shocked by this data because I thought it was going to be a lot more crazy. 54% of the referral reasons to get to the BHC was related to like mental health concerns. 23% were related to physical health conditions like diabetes, like hypertension.
That's amazing.
It's not. I was shocked.
Percentage as I've ever heard.
I was honestly, there was a point where we were looking at the data and we're continuing to do it now. As you know, we just switched to Ocean and Epic, so we'll see how this goes. But the thing that becomes interesting is that I was blown away because I was like, there was no way that, and again, who knows what the hell it should be, but it just seems like a large percentage that I was totally baffled by. I was shocked.
That's amazing. It's the best that I've heard. You got to write that.
I'll put it down.
That's a paper for family systems and health.
Cool.
Important paper. But it ain't good enough because the question is, what happened to those patients?
Exactly.
Are
it's
there
cool they got referred.
Diabetes outcomes.
Correct.
Blah, 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 blah. So for me, that's the cutting edge of integrated care.
Hmm.
You know, I often teach, I don't care about anxiety and depression. You know, what I care about is multimorbidities with
Love it.
behavioral comorbidity.
Love it.
And that's the crux and focus of my work, my research, and my assessment of the field. And I wish the rest of the field would catch up to that.
You know, Rodger, the one thing you said at the beginning when we were before shooting that I thought was really, really profound is like this idea that it's like, it's almost like integrated care has rested on, as you were saying, like, it's just a good idea, right? Like, it just makes sense. Like, it intuitively makes sense. The problem with that is that good ideas might not actually be true. You know, they might actually not produce the things that we're thinking that they were producing and what we're
Yeah,
looking.
you're absolutely right.
Man, it's interesting. So let me
So
ask, oh, go ahead,
that's
go ahead.
the story, and that's how I've gotten to where I am at the moment. Um, uh, I'm generally not impressed with the field.
Hmm.
Um, and, you know, the dilemma is we can identify 50 people around the country who have been the major contributors to integrated care. And when you look at innovations, most of those folks are the people involved in them. And that's not good enough.
Hmm.
You know, the people who are doing all of this great work at local settings got to get contemporary. And contemporary means three things.
Well
Integrated,
said. I love that. What was it again? The local people have to get contemporary.
yeah,
Ah,
yeah, and they're not.
I
They go
like
to the
that.
CFHA and hear the same stuff over and over and over again.
I like that.
Um, and so there are three things. We know from our data that engagement in workflow is the primary determinant of impacting on patient outcomes. We have to measure patient outcomes, and we have to, and one of the key measurements is complexity. We have to identify the highest risk patients, and those are the folks that we need to be talking about. And the highest risk patients are the patients with multimorbidities. How we deal with social determinants of health is a whole different conversation that I'm perplexed by. I often hear myself saying, I don't care about collecting social determinants of health data because I only care about collecting data if it's actionable.
That we can
And
do something with, that we're
yeah,
going to be able to, yeah, yeah.
yeah. And to collect social determinants of health and it become another place to store it in the EHR with nothing actionable based on that, it just doesn't motivate me to do very much with, if that makes any sense.
No, Roger, that gets, again, it gets, all these things that you're saying gets me hyped because I think it's a one thing that we often look at, even, you know, this probably isn't the best analogy, but I think it's also even similar to like, hey, you know, collecting PHQ-9 data only matters like if you're doing something afterwards with it. You know, like, are you actually doing something, an intervention? Are you showing some outcomes? Are you doing something with this? Versus, you know, I remember I've told this story a million times. When I went into my doctor's office, they did the PHQ-9 and I asked the MA, it's like, hey, if I would have said yes to those questions, like what happens? And she said, I don't know. And that's the same thing with, I almost feel like when you were talking with the social determinants of health data, where it's like vital information and like there has to be a follow-up to this. Like there has to be, we just not.
That's right.
Yeah, 100%.
And if you talk to Frank Degree and the folks that were doing stuff in Colorado, the follow-up has to be out of the healthcare office. And if there's not a community-focused ability to navigate all the needs that are implicit in that structure, then we're not going to make any progress again.
Amen.
So
Amen.
you wind up being cool because you're collecting social determinants of health and you can check it off on some national metrics, but it's irrelevant in terms of care and practice.
Rodger, and this is something that, and I have to run to supervision in 5 minutes, which is pissing me off because I want it. We're going to have part two to this conversation. I'm going to email you, set up another time.
Happy to do it. Happy to do it.
Because what you're saying there, I think, is something that is profoundly impactful for our entire field on a variety of different things. This idea of like, hey, we know these things, we're collecting data, it's cool. What are we doing with it though? Like, what's our response to it? And as you said,
and are we collecting the right data?
Interesting.
So, for example, I think PHQs are irrelevant. They had a huge importance in the field, huge,
yes.
But that's 20 years ago.
Amen.
You know, when you ask patients what's important, the patients say the quality of my life. So again, if people are thinking about measurement, think about quality of life.
And what would you recommend? Would you say, because I know we're doing this too. I mean, we've used the Duke before. We're thinking about using the Promise now because it's part of Epic. What would you recommend?
Useless. No data, useless.
Okay.
Promise is a great research measure.
Okay.
But out in the field, down on the ground, we can only collect limited measures. So we have to collect measures that have both research utility and have to have clinical utility.
Hell yeah.
And that was not the design of the Promise.
Gotcha.
So if I know you got to run, I'll just put a plug in for John Ware. Okay. John Ware was the author of the SF36, 24, 12,
yeah.
blah, blah.
Yeah.
He has developed a brief quality of life measure, takes 2 minutes, called the Quality of Life Generic, QGen, that generates a physical and a mental health score that has great research utility, is incredibly predictive, and is an excellent clinical tool to both identify high-risk patients and monitor how they're doing.
Cool.
So when we get to part two, that's an area that I would love to talk about.
Right, we're going to do part two. We're going to do part two soon. I'll follow up with you. I cannot express my gratitude enough for this. One, just hearing about the story, and the one thing that I love that you started out with, which is usually what these like past stories of these pillars in the field and stuff. It's like a lot of it was accidents, and a lot of it, as I'm sure, as you said, was saying yes, eating in cafeterias, making relationships that just rippled out in really profound ways. And I hope people, particularly like students that are even watching these, it's like take opportunities. You step outside of your comfort zone, say yes to things. You never know what's going to ripple out. But this conversation right now that we're having about outcomes and what we should measure, that shit, that gets me hyped. That gets me really hyped.
That's great. And if there's anybody listening who wants to get involved in this next national research project, hassle you or hassle me.
I'm going to put your email right in the thing about with the YouTube when we get it going.
Excellent.
Yeah.
Great
hey, thank you for today.
Regards to Bridget, and I'm out of here.
All right, my man. Take care, dude.